Okay, hi everyone. Good morning from the UK. I'm sure it'll be afternoon in India. It's a great pleasure to be with you. I'm sorry I cannot be in person, my favorite country to visit, as you all know. My name is Khunti. I am a general practitioner and professor of primary care and vascular medicine at the University of Leicester. It gives me great pleasure to present to you a new dimension in type 2 diabetes management, renal and cardiovascular perspective. These are my disclosures. Over the next few minutes, I'm going to go through definitions, pathophysiology, epidemiology, prevention and management guidelines, and then summarize our talk and give you an opportunity to ask some questions. In terms of definitions, this is the definition of chronic kidney disease, defined as abnormalities of kidney structure or function that are present for more than 3 months. That's really important with the implications for health, and that's why you need to do these tests twice. Diabetes is, as you all know, a major risk factor for development of CKD. Diabetic nephropathy, this is diabetic kidney disease, is a subtype of CKD seen in people with diabetes, and this is defined as deterioration of function of the kidneys from long-standing diabetes, usually, not always, in the presence of albuminuria. DKD is the leading cause of end-stage renal disease, and data from UK and US show that about 40 to 27% of people with diabetes who have DKD, end-stage renal disease is due to diabetes. So with chronic kidney disease, we need to have abnormalities I'll just get our abnormalities of the kidney function for more than 3 months. So you need at least 2 tests. Diabetic kidney disease is within the chronic kidney disease, and this is a subtype of CKD with deterioration of kidney function from long-standing diabetes, usually in the presence of albuminuria. So what we need is 2 eGFR results less than 60 over a period of at least 90 days without markers of other kidney damage, or more than 60 mils per minute of eGFR with albuminuria ACR greater than 3. So there are 5 stages of DKD. We get the early phase, reversible glomerular filtration, then we get normal glomerular filtration and normal albuminuria, then we go to incipient nephropathy with normal glomerular filtration, moderately increased albuminuria, then severe increased albuminuria, progression to reduction in eGFR. This is where the urine albumin creatinine ratio grows greater than 30, and then ultimately end-stage kidney disease. So there's a number of ways we can detect proteinuria. We can use a dipstick, but this is not sensitive or specific enough. So we have ACR or PCR, albumin creatinine ratio or protein creatinine ratio. And ACR is the preferred test for detecting people with type 2 diabetes for proteinuria, because it seems to have a greater sensitivity than PCR at low levels of protein. Usually the sample needs to be done in the morning, but the tests are so specific, sensitive that you can do this at any time. And these are the definitions. HCR less than 3 this is normal. 3 to 70, you need to repeat this ideally with an early morning sample to confirm. And anything above 70, this is a significant abnormal test. But we do need to check things like urine tract infections as well, and that's why we often check it again. In terms of the pathophysiology, we know there's an interlink between cardiac and kidney disease, and we're seeing more and more of this since we've got the new therapies. So we get hyperglycemia that can affect the heart directly through inflammation, oxidative stress, myocardial dysfunction, but it can go through other pathways where you get hyperfiltration in the kidneys, interglomerular pressure increase, albuminuria increase, and then renal fibrosis, progression of CKD and DKD, and this is through activation of sympathetic nervous system playing on the heart. And again, these are the associations with myocardial damage and eventually heart failure. In terms of the epidemiology, we know, again, as I've said, everything is interlinked in terms of diabetes, cardiology, and nephrology. We do need to work together now. More and more we're seeing that this is a multidisciplinary management of a condition, and I would put primary care on top of this, because they look after all these patients in the early stages, and then we tend to refer these patients to the specialist as and when necessary. And so, we get the type 2 diabetes, CKD, cardiovascular disease, and chronic heart failure. And this is that's why a lot of people are saying this is cardiometabolic renal disease or CARE-ME disease, the new term that's recently being introduced. Again, just going through type 2 diabetes and CKD, we have a number of vascular risk markers here. We get hypertension is, as you know, a major risk factor for cardiovascular disease and CKD. 75% of people with diabetes who have cardiovascular disease is attributable to hypertension. Same as hypertension leading to CKD, and CKD and type 2 diabetes are also interlinked. CKD is the commonest cause of, or is because of diabetes, and we know CKD also worsens diabetes control. There's also issue about hypoglycemia we'll come to later. And type 2 diabetes, as you know, is linked completely with cardiovascular disease. So a lot of interplay of risk factors. In terms of diabetic kidney disease, we have a number of consequences, and again, it's just straight from diabetic kidney disease with cardiovascular events, renal events, huge impact on cognitive dysfunction, dementia, cardiovascular death, and obviously mortality. So we shouldn't take diabetic kidney disease very lightly. So what's happened in terms of the incidence of diabetic kidney disease? We don't have data for India, I haven't seen. We have data for the UK, but it's very similar to what we see here in the US. This is Ed Gregg, a good friend of mine who has now moved to the UK, did this lovely study in the New England Journal of Medicine. And as you can see, over the years, in people with diabetes, acute myocardial infarction, stroke, amputations, deaths from hypoglycemic crisis have all reduced. However, if we look at the end-stage renal disease, this seems to have remained flat, and that's the case also in the UK as well. This is data from Canada, again showing that diabetes is increasing and renal vascular disease is remaining flat. No change there at all. And these are other reasons for renal disease, but diabetic kidney disease remaining pretty flat or increasing indeed. In terms of hospitalization, this is a Canadian chronic surveillance system, shows that people with diabetes and CKD have 6 times more likely to be hospitalized for CKD and 12 times more likely to be hospitalized for end-stage renal disease. So huge amount of costs implications once CKD is developed in people with diabetes and DKD is developed. So it's really important that we want to try and reduce the risk of development, which will hopefully reduce the risk of all these long-term risk factors and consequences as well. We've already said 40% of people with type 2 diabetes will have DKD, and stage 3 to 5 CKD in type 2 diabetes is predicted to be about 50% increase between 2012 2025. Mainly because a lot of people are living longer, we've got better therapies, and they're surviving much longer. And we've already said in terms of moderately increased albumin, it doesn't have to be hugely increased, just around the 3 mark is an early marker, and 20% of people will develop albuminuria, increased albuminuria within 10 to 15 years if they have early disease. And about 80 to 90% of these will progress to advanced disease if we don't do something about it, and we'll come to what we can do later on. So people with diabetes and CKD are high risk for losing their kidneys and major cardiovascular events. So this is a triangle that it happens in synchrony sometimes. So in terms of CKD, we get albuminuria, decreased eGFR, kidney failure, but at the same time you get simultaneous worsening of cardiovascular disease with the cardiac atherosclerotic disease, left ventricular hypertrophy, eventually cardiovascular events, and eventually heart failure. So both of these can be occurring at the same time, independently of each other. Now, some of the really nice classical epidemiology of the associations of CKD with cardiovascular disease. This is showing that as eGFR decreases, the risk of cardiovascular events increases. This is a large US database, and this is looking at the EGFR greater than 60. This is age standardized rates of cardiovascular events per 100 person years. So 2 per 100 person years if they have stage 1 to 2, stage 3, 4 per 100 person year. Stage 3B, this is EGFR of 30 to 44, 11 per 100 person per year. As soon as we start getting to stage 4 and stage 5, this is EGFR of less than 30 and less than 15 here. Look at the rates here. 36 events per person per year when the EGFR goes to below 15. So this is what we want to do. Try and catch people earlier than this and stop progression. Stop progression into here. Also, in terms of mortality, previous slide was regarding cardiovascular events. This is regarding mortality. And again, this is looking at standardized 10-year cumulative incidence of mortality. So this is age-matched controls without diabetes. So if they have type 2 diabetes, there's an 11% increase in 10-year cumulative mortality. Age-matched would be about 7%. If they have type 2 diabetes and albuminuria, 25% will have mortality within 10 years. Type 2 diabetes and impaired EGFR of less than 65, 31%. And if you have type 2 diabetes, reduced EGFR and albuminuria, the classical DKD, 54% of people will have mortality at 5 years. So quite drastic impact, not just in terms of cardiovascular events, but mortality as well. This is some more data looking at myocardial infarction and mortality. So top is myocardial infarction. This is a really nice study comparing, is DKD equivalent to myocardial infarction? So these are people with previous myocardial infarction here. And these are people with either DKD, CKD, diabetes, or no diabetes or DKD. So if we look at this, if people have diabetic kidney disease, it's nearly equivalent to someone who has had a previous myocardial infarction in terms of another myocardial infarction. If they've had a myocardial infarction, if we compare that to people with DKD or even CKD and diabetes, then all-cause mortality is greater than previous myocardial infarction. So it's not just risk equivalent to someone who's had a myocardial infarction, but it's greater than someone who's had a myocardial infarction. This is looking at hospitalization, and what we see here is hospitalization for heart failure. And again, this is looking at separately for EGFR and albuminuria. Left-hand panel, EGFR. As the EGFR decreases, you get increased hospitalization here up to EGFR of 15 to 19. These are rates per 1,000 person per year. So 35 per 1,000 people would be admitted with heart failure if they had a low EGFR of 15 to 29. We see a reduction here, most likely because these people die before being admitted to hospital. So this is a really large study, 266,000 people with a median follow-up of 5.6 years. So very, very solid data. Now looking at EGFR, albumin-creatinine ratio, less than 3 in the normal range. And this is the severe range, 30 macro albuminuria. And these are events per 1,000 person years again. And as we see, hospitalization for heart failure greatly increased as soon as people have urine albumin creatinine ratio that is positive for microalbuminuria. And this is another nice study looking at the combination of both EGFR and urine albumin creatinine ratio with cardiovascular events, cardiovascular death, and renal events as well. So here in cardiovascular events, as you can see, reasonably flat line with normal albuminuria. This is microalbuminuria, this is macroalbuminuria, and these are the EGFR categories here. So the highest rates, hazards ratio of 3, is people who have a low EGFR and macroalbuminuria increased here. Microalbuminuria and a low EGFR in the middle here, and normal microalbuminuria but high EGFR, so low GFR, you get reduced rates. The lowest rates are people who have normal EGFR and no albuminuria here. That's the standard. reference point. So as you can see, as soon as you have either microalbuminuria or macroalbuminuria, you're going to have increased events. Looking at cardiovascular death, again the same picture, hazards ratio 6-fold higher when you have EGFR less than 60 and microalbuminuria, and hazards ratio 4 if EGFR is less than 60 and people have microalbuminuria. And this is renal events, it's a composite renal events including renal deaths. And again, you get much, much higher. This is 20, hazards ratio of 20 as soon as you have microalbuminuria and EGFR of less than 60. Now that's giving you the hazards ratio of people, but what we want to look at is what's the life years lost once people have CKD or DKD. So this is a really nice study looking at life years lost, life expectancy here. Okay, so someone aged 30 here, life expectancy if they have early DKD is 40. If they just have diabetes, it's here about 55. This is life expectancy, the number of years. If they have early CKD, it's here, and if they have just this is the reference point. I'm sorry. At the top is the reference point. Someone without any of these diseases, so they'd live to be about 85. But if you have DKD, you have about 14 to 16 years of life years lost with men and women. So early onset of CKD in the age of 30 to 35, you lose about 14 to 16 years, which is quite drastic. Now, obviously, all of us want to ask about questions about ethnicity. There's very little data on ethnicity. This is a systematic review that we conducted looking at ethnicity and diabetic nephropathy, and we found no significant link between South Asian or African Caribbean ethnicity and the prevalence of microalbuminuria. However, there was a preponderance for higher rates of disease progression in South Asians compared to white participants once they developed microalbuminuria. So it seems that towards development of microalbuminuria there is no difference between ethnicities, but as soon as Asians or blacks develop microalbuminuria, there seems to be a higher increase in terms of worsening of to microalbuminuria. This is STENO2 trial. All of you know this well. This is looking at mortality, all-cause and cardiovascular events. And again, we see that multifactorial intervention. This is intensive therapy. This is conventional therapy. You get a reduction in cardiovascular events and mortality as well. And this is looking at intensive therapy in the blue and conventional therapy in the brown color. Death from cardiovascular events, stroke, myocardial infarction, coronary artery bypass grafting, PCI, revascularization, amputation, all of them much increased in the conventional group. And with multifactorial interventions, we can reduce all of these impacts. And as you know, multifactorial interventions included RAS inhibitors, blood pressure management, lipid management, and HbA1c control. In terms of prognosis for CKD, there is this traffic light that one can look at, and this is based on the data that I have just presented by the KDIGO guidelines. KDIGO guidelines have just been updated. They should be online soon, if not already, and I had the pleasure with Nikhil Tandon, in fact, from India, to be part of that. And the traffic light system is basically anyone who has an EGFR that goes down to below 30, and you start getting micro and macroalbuminuria, and these are the people who are at the highest risk here, which we really need to control. These are high risk, but these are extremely high risk. So anything an EGFR 45 to 59 with a normal microalbuminuria, then they may be classed as a moderately increased risk. But anything above that, we really need to take it seriously. So prevention and management. This is managing diabetes in the community, so primary care practitioners, things that we can do simply and we can do well. Controlling the blood pressure and HbA1c is the mainstay. First of all, HbA1c, trying to aim for an HbA1c of 7%. aiming for a blood pressure of less than 130/80, manage other risk factors, lipid control, thrombosis, anticoagulations, antiplatelet if they have things like atrial fibrillation, lifestyle adjustment, low salt diets, exercise, smoking cessation, dietary supplements. The data for this dietary supplements is not that huge, but the recommendations that we should be managing them with iron and vitamins and possibly calcium supplements and vitamin D. The other therapies, cardioprotective therapies, as you all know, ACE inhibitors and ARBs. This is hospitalized erythropoietin. I would not be doing that. These are patients who's getting the anemia, who I would refer to the specialists. Preventing DKD or reducing DKD progression could reduce, as we've said, the cardiovascular events in people with diabetes. As EGFR and microapnea progress, then we get worsening of cardiovascular events and mortality, and this is where we start seeing increased risk of heart failure, myocardial infarction, and stroke. And this is why what we've said about detecting early in terms of DKD and preventing or slowing the progression by the therapies that we've just mentioned, that's the mainstay, really. We know in terms of A1C reduction, you get reduction in CKD. This is looking at less microapnea and reduction in macroalbuminuria as well. And these are all the studies that you know are called Advanced UKPDS, VADT. So benefits of microvascular outcomes and macrovascular outcomes if we control HbA1c. This is looking at Advance On study. And this is Sofia Zunga's good friend, who again showed that over intensive control reduced end-stage renal disease. Here we see separation at 4 years, and this is Advance On, as you know, was the follow-on up to 10 years. Now, coming on to the excitement in the newer therapies we've had data from SGLT2 inhibitors. I'm just showing you here Canvas trial with canagliflozin, EMPA-REG trial with empagliflozin, and DECLARE-TIMI trial with dapagliflozin, all very large cardiovascular outcome trials. And then the GLP-1 receptor agonist, leader with liraglutide, and SUSTAIN-6 with semaglutide. Now, these were safety trials, but as you know, they really blew us when we saw the results in terms of cardiovascular outcomes. But there were unexpected results, and these were the renal outcomes and the heart failure outcomes. None of us expected that. And so if we look at the data here at the bottom, we can go through all of this, but in view of time, you know this data, but let's just concentrate in terms of the renal disease here. We get a 40% reduction in a Canvas trial. And the renal composite endpoints were slightly different, but you can say there are renal benefits. EMPA-REG outcome trial, DECLARE-TIMI, slightly less reduction, but this was a broader population. EMPA-REG outcome trial had everyone who had previous established cardiovascular disease. In Canvas, about 40% didn't have established cardiovascular disease. DECLARE-TIMI, about 60% didn't have established cardiovascular disease. So they had a lot of people with normal EGFR and lower risk factors of cardiovascular disease. But even then, we see reductions. So for a broad population, we see benefits of SGLT2 inhibitors in people with diabetes. And this is the leader in SUSTAIN. Again, the definitions were different, but again, we see reductions that are in line with some of the results found in the SGLT2 inhibitor studies. And then if we look at the hospitalization for heart failure, here all the benefits were for the SGLT2 inhibitors, massive reductions, anything from 35% onwards reductions in hospitalization for heart failure. This is looking at the Kaplan-Meier curves for the key exploratory renal outcomes, and what we see here, these are the definitions here at the top. So Canvas composite renal outcomes, sustained 40% reduction EGFR, requirement for renal replacement therapy, or death from renal causes. Here slightly different, but the death from renal causes and renal replacement still remained. And here there was a slightly different definition, but overall all of them are similar, and they're all clinically meaningful definitions. But what we see here in the Canvas trial is separation occurring quite early on. This is number of days here. Again, we look at separation here. Within 18 months, we saw separation in the EMPA-REG trial here. And declare TIMI, again, within about a year or so, 1.5 years, we see separation between dapagliflozin and placebo. So the reductions we see in the composite endpoints occur quite early on. These are the MACE benefits. Just to rehearse them, you all know these. EMPA-REG outcome trial, Canvas trial, declare TIMI, we see reductions in MACE, which was significant for EMPA-REG and Canvas, just missed significance for declare TIMI here, and likely here because they had a low risk population. Credence, slightly very different population, as you know, with renal disease, and there was no benefits, significant benefits for MACE outcomes, but all in the right direction. This is looking at people at the bottom, in people without atherosclerotic cardiovascular disease. And what we see here, there were only 2 studies, as I mentioned, Canvas and Declare. There was no benefits in people without atherosclerotic cardiovascular disease. But if they had renal disease without atherosclerotic cardiovascular disease, there were major benefits in terms of major adverse cardiovascular outcomes. This is summarizing all the renal endpoints, again, looking at EMPA-REG, Canvas, Declare TIMI, and the Credence trial, all of them showing improved renal outcomes. These are events on the left-hand side, events per 1,000 person per year. People without atherosclerotic cardiovascular disease in Canvas, Declare TIMI, and again, you see reductions in renal composite endpoints. So whether you've got atherosclerotic cardiovascular disease or not, so anyone with diabetes, they would benefit with SGLT2 inhibitors. This is looking at 3-point MACE, which we've just gone through. This is a meta-analysis of 3-point MACE for the 3 trials, EMPA-REG, Canvas, Declare. The 14% reduction is a very similar 14% reduction on 3-point MACE. And if we look at patients with multiple risk factors, no benefits there at all. But if we go to hospitalization for heart failure or cardiovascular death as a composite, you get a 24% reduction in people with established cardiovascular disease, and about a 16% reduction, which was just missed significance in patients with multiple risk factors. I haven't put down the data for Vertis because I haven't seen a meta-analysis yet. I'm sure it's out soon with ertigliflozin. But ertigliflozin, as you all know, did not meet its primary outcome of a MACE. The hazard ratio was 0.97, non-significant. We can discuss that. There could be many reasons. We're all still wondering why that didn't meet its primary outcome, because all of us until then thought that this was a class effect, and this has certainly thrown us into discussions in the diabetes community. However, what they did see is consistent results for heart failure, hospitalization for heart failure, with about a 30% reduction in hospitalization for heart failure. Renal endpoints as well, it was a 0.81 hazard ratio, but failed to reach statistical significance. So, summary of renal data with SGLT2 inhibitors, reductions in albuminuria or rate of EGFR decline, all of them, as you can see, canagliflozin, dapagliflozin, empagliflozin, all reduction. This is the composite endpoints here at the bottom, which we've just gone through. And if you look at that with angiotensin reception blockers, these are the previous studies, all studies that have been done, the hazards ratio are even better than what we see with ARBs and ACE inhibitors. Very, very exciting times, I think. And we can again discuss the DAPA-CKD study that has just been published. And just to rehearse that, this was for 4,000 people who were randomized to either dapagliflozin or placebo. And the interesting thing about this is 68% had type 2 diabetes. 32% didn't have type 2 diabetes, and we see a reduction in both people with and without diabetes in terms of about a 39% reduction in composite renal endpoints. There was also reduction in hospitalization and heart failure for about 29%, and exciting results of a 31% reduction in all-cause mortality as well. So quite exciting times ahead with SGLT2 inhibitors, I think. This is interesting data looking by baseline EGFR for a systematic review for the 3 studies that we've got, EMPEREG, CANVAS, and DECLARE. So this is looking at baseline EGFR less than 60. We see a reduction here of about 33% for renal composite endpoint. If we have a baseline EGFR of 60 to 90, we see a greater reduction, greater benefits, a 44% reduction in composite renal endpoint. In people who have a baseline EGFR of greater than 90, we see about a 56% reduction. So this consistent, but people with a baseline EGFR which is greater, sometimes you see a better improvement in renal outcomes. So those are from randomized controlled trials. We've just recently looked at real-world studies. This is Hido Herspring, who led on this study with us on the CVD Real study. This was a number of patients from around the world. We had 65,000 people from 5 countries. Baseline EGFR was about 90. And what we see here is the mean change in estimated EGFR. So this here is what we would see in the light green line. Here is the reduction in EGFR over time, 24 months, in people who were not on an SGLT2 inhibitor. Here, people on SGLT2 inhibitor, as we see, you get a decline in EGFR, which comes back, and after that there's maintenance or preservation of EGFR. The beneficial effects that we see in the randomized controlled trial now translating into benefits in the real world setting as well. We worry about hypoglycemia is a risk factor for people who have CKD, and we are always changing therapies and adding therapies to improve glycemic control because it's a progressive disease. And CKD is a risk marker for hypoglycemia. This is a really classical study where the reference point here was people without CKD and no diabetes. This is people with CKD but no diabetes. This is CKD, no CKD but diabetes, and this is CKD and diabetes. This is looking at incidence rate ratios. So even in people with just CKD with diabetes, there's a 62% increase risk of hypoglycemia. So it's showing that people without diabetes can hypoglycemia. Hypoglycemia here defined as a blood glucose of less than 50. People with diabetes without CKD, 4-fold increase, and people with CKD, this is 2-fold increase compared to people who have diabetes with no CKD. As soon as you have CKD, the hypoglycemia rates are doubled. These are some of the referral criteria that we would use in the UK for primary care. Who do we refer in terms of CKD? Well, EGFR category 4 to 5 without absence of diabetes, we would refer to a renal physician. ACR, which is greater than 70, unless it's been caused by diabetes and we're treating all the therapies and it's still declining, then we would. ACR greater than 30 and hematuria. Progressive fall in EGFR of greater than 25%, and EGFR category or sustained decrease in EGFR of greater than 15. Uncontrolled hypertension if they're on 4 therapies, known or suspected rare or genetic causes, and suspected renal artery stenosis, which I've seen once when I was doing my training. I haven't seen that in primary care yet. So what do guidelines tell us? Well, this is the updated ADA ESD consensus statement recommending SGLT2 inhibitors and GLP-1 receptor agonists in people with atherosclerotic cardiovascular disease, heart failure, or CKD. So we know first line is metformin and diet and exercise. But if they have atherosclerotic cardiovascular disease, and that's the predominant, then one would start with either an SGLT2 inhibitor with proven cardiovascular benefits, if the EGFR is adequate, or a GLP-1 receptor agonist with cardiovascular benefits. Now, this is the interesting area that we're going to see where it says where EGFR is adequate, because I'm aware that in the UK, for example, EGFR, where we can prescribe SGLT2 inhibitors, is an EGFR of greater than 60. However, many countries have gone down to 30. For example, Brazil, I think Canada is moving that direction as well. If the EGFR is still high once they're on one of these therapies, then you would start with the second therapy. So if you were on SGLT2 inhibitors and HbA1c is above target, then you'd go to a GLP-1 receptor therapy, or vice versa. And then you'd add on all the other therapies that we have in our armament. If heart failure or CKD predominates, then one would go for an SGLT2 inhibitor with evidence for reducing heart failure or CKD progression from the cardiovascular trial that we have just mentioned. If SGLT2 inhibitors are not tolerated or contraindicated because of the EGFR categories, then one would add a GLP-1 receptor agonist. So it's a quite clear guideline. First time we're having evidence-based guidelines that have been based on cardiovascular outcome trials, which have shown heart failure and renal benefits as well. So in summary, we could have one patient, one disease with number of consequences. One patient with diabetes could have CKD, heart disease, and cardiac failure. You could have someone with just CKD and they would have all of these in terms of risk of cardiovascular disease, insulin resistance, hypoglycemia risk. If you have type 2 diabetes, we've gone through and rehearsed in terms of the risk of cardiovascular events, CKD, and mortality. If they have ischemic heart disease, this is the commonest cause of death in people with type 2 diabetes. And heart failure, again, this is the exciting area we're seeing in heart failure, that more and more work will be coming out. We've also got the Emperor trial recently come out. We've had the DAPA-HF trial, again showing benefits of SGLT2 inhibitors in people with reduced ejection fraction, both people with and without diabetes. So the CAMI, the cardiorenal metabolic syndrome, we need to now embrace that, and we need a holistic approach, especially in primary care where we manage majority of these patients. I know in different healthcare settings it's different, but in the UK 90% of people with type 2 diabetes would be managed in a primary care setting, and we would be managing all of these risk factors in a primary care setting. And then when we have in terms of complications, that's when we would be referring to our specialist colleagues. So in summary, diabetic kidney disease is a subtype of CKD defined as deterioration of the functioning of the kidneys from long-standing diabetes, usually in the presence of albuminuria. Cardiovascular disease is one of the main causes of deaths in people with chronic disease. Albumin-creatinine ratio is what we should be using to detect early signs, and we recommend that people with diabetes should have this done annually. Although morning sample is preferred, the initial sample can be taken at any time, and if it's we show microalbuminuria, then we would do that again and do an early morning sample. But if it's macroalbuminuria, you can take that as read unless you're suspecting urinary tract infections. Besides all the risk factor management with everything that we have, blood pressure, renal, blood pressure, lipids, and HbA1c, using them, putting them into RAS inhibitors, now we have more therapies in our armament in terms of SGLT2 inhibitors and GLP-1 receptor agonists that can reduce the risk of renal and cardiovascular events in people with type 2 diabetes and diabetic kidney disease. But I think we will see this extended to people without diabetes as well. Early interventions improve glycemic control. So I think, again, this issue about therapeutic inertia, we need to pick these people up early. We need to get risk factor control early, not waiting years for HbA1c control, blood pressure control, and lipid control. All of these have shown that there is a legacy effect for all of them, not just at HbA1c. So we need to manage these aggressively early on from the disease onset. If we do that, these people will have HbA1c control, blood pressure control for longer, and will reduce the risk of these complications for longer. We need to surveillance these people for diabetic kidney disease to avoid hypoglycemia as well when we're using new therapies. Surveillance, as I've said, normally would recommend going for targets of annual check with a urine ACR test. Tight blood pressure control once people have DKD, maximum last blockade, and really a holistic approach in managing all the risk factors in these populations. Thank you very much for listening. I'm happy to take questions. I hope you heard that all right and the slide deck was okay. There's a question here. If a patient doesn't have any complications over the last 2 years, should I still ensure a treatment from preventing complications in a very strict manner? Absolutely. So if a person has diabetes, as soon as we diagnose them, the risk factor management, blood pressure, HbA1c, lipids should definitely be happening. If they have hypertension, we should be putting them onto RAS inhibitors, and obviously all the other lifestyle factors in terms of diet, BMI, smoking, all of that should be implicated, and we should be advising patients to do that. There's some really nice study that's come from Sweden. If we manage all the risk factors tightly, including smoking cessation, the BMI is all right, then the risks for a person with diabetes is the same in terms of mortality or cardiovascular events as someone who doesn't have diabetes. Just showing that we can reduce their risk dramatically if we act early. Okay, I think there are no more questions. With that, I will say thank you very much. Have a good rest of the day and hope to speak to you all soon. Thank you. Goodbye.